For the clinical presentation of acute kidney injury, you need to know that you should first start with the clinical presentation of the disease itself. Is it clear? Which is acute kidney injury. Now, when you want to when you want to have the clinical presentation of the disease, is it clear? Which is acute kidney injury. You need to know that generally on the definition of acute kidney injury that we had a category classification where we have used where we have said that the urine output has to be less than 0.5 mils per kilogram per 6 hours. So if you have a category classification if you have a urine output that respect exactly that term of the category classification, you can already say that the patient has an acute kidney injury based on your history taken on your physical examination. Is it clear? The next thing is that you have to evaluate for the cause and the risk factor of the acute kidney injury. Is it clear? So we have evaluated multiple risk factors, and you can take those risk factors from your past histories. Is it clear? So the patient has a past history of a relative hypovolemia or a past history of an absolute hypovolemia, which can bring it toward a mechanism of acute tubular necrosis. We have seen that. The patient has a risk factor of a chronic inflammation, which can bring him to a pathophysiology of or an acute inflammation, which can bring him to a pathophysiology of a acute glomerulonephritis, like in the case of a post-streptococcus glomerulonephritis, where you have infections of the skin. I've already said that. Is it clear? So it is based on what you have in a patient that you're going to understand which physical examination you have. Is it clear? So now I'm not going to emphasize too much on the risk factors again. Is it clear? So what I'm going to bring out is how can you identify from the physical examination and the history that if this is much more going to be toward an acute tubular necrosis, going to be toward an interstitial nephritis, or going to be toward an interstitial nephritis, or going towards an acute glomerulonephritis. Now, on physical, generally, you need to know that in a case of acute tubular necrosis, is it clear? The urine of the patient, and in this case, is much more brownish. Is it clear? Generally, on the history taking and the physical examination, the urine is much more brownish in a case of acute tubular necrosis. That's the first point. And now you also need to know that there are phases inside acute tubular necrosis. The first phase is usually the oliguric phase, where the patient is not urinating and the patient has signs of fluid overload. Is it clear? And the fluid overload, it is much more intravascular and interstitial. Is it clear? So the patient may not have edema, but maybe the patient may have high blood pressure from the acute tubular necrosis. Is it clear? So we have oliguric phase. The oliguric phase, you may have just signs of fluid overload. Is it clear? So the patient is not urinating with signs of fluid overload. And then I've already explained you the fact that you have three major body compartments. We have the intracellular fluid compartment, we have the interstitial fluid compartment, and we have the intravascular fluid compartment. Now, for the interstitial fluid compartment, we need to know that it mostly contains potassium ions and proteins. Is it clear? Proteins inside the cells, or even phosphate ions. Is it clear? Now, for the intercellular space compartment, the interstitial fluid compartment, it mostly contains sodium ion and chloride ion, while the intravascular space compartment mostly contain the sodium ion, the chloride ion, and also the proteins like the albumin. Is it clear? Now, you need to know that generally, when you have acute tubular necrosis, there is no loss of sodium ion, there is no loss of chloride ion. It means that these two compartments are going to be increasing in volume. So the patient is going to have hypertension or high blood pressure. Is it clear? The patient has hypertension, and the patient may have some edema, and this edema is going to be interstitial edema, which is going to be shown as interstitial edema. That is going to be shown as is going to be interstitial edema. Is it clear? Now, provided that now we have an increase in urea, you're going to have now a shift of urea inside the intracellular space before you can have now intracellular free edema, which is going to result to cerebral edema and a uremic encephalopathy in acute tubular necrosis. Is it clear? So this is usually, you need to know that what it is, the stools in acute tubular necrosis is brownish, and then you are going to be oliguric. The first phase is that we have oliguria within the first 3 days. Is it clear? You have oliguria within the first 3 days. Then you need to know you are going to have the polyuric phase. The polyuric phase generally from 3 days to 7 days, and then you have the recovery phase. Is it clear? From 7 days to 14 days. So if you have a patient that is going to respect this format, is it clear? So you should think of acute tubular necrosis on your history taking and physical examination. Now the next element is going to be for acute interstitial nephritis. Is it clear? Generally, for acute interstitial nephritis, what is going to make you think of acute interstitial nephritis is that the patient is going to have, he may have an abdominal mass. Is it clear? An abdominal mass, flank mass. Is it clear? When you have an abdominal flank mass, the abdominal flank mass is just being as a result of the kidney. Generally, when the interstitium of the kidney is inflamed, the size of the kidney increases, because the interstitium is what is going to make up the greatest amount of the kidney. Is it clear? So when you have interstitium is inflamed, the size of the kidney increases because it is making the greatest amount of the kidney. So it's going to generally present as an abdominal mass, and when you palpate the kidney, is also going to be painful. You have a tender kidney. It also tells that you have an interstitial nephritis. Now the next one is for acute glomerulonephritis. How do you know? This is with urine. The urination, generally acute glomerulonephritis, is going to be foamy because there is a proteinuria. Is it clear? The urination acute glomerulonephritis is going to be foamy because of excess proteins inside. Is it clear? And then the second element after foamy is that there may be hematuria. The color here, the color in this case may be reddish. Is it clear? So it is not always reddish, it may be reddish. Is it clear? So you have foamy and it may be reddish, and you may have pedal edema. Is it clear? So pedal edema because the proteins in the urine is going to be low. Is it clear? So fluid is going to accumulate in these two compartments. Is it clear? Proteins in the intravascular fluid is going to be low because of fluid proteins lost in the urine. So you are going to have fluid accumulation in the intercellular space. So you may have a pedal edema. Is it clear? So those are the different elements that you have to evaluate also on physical examination to know for acute kidney injury. Now we visualize now for the clinical presentation now for chronic kidney disease.